Welcome to KIMEcast, where we break through and cut the BS in sports medicine, rehabilitation, and sports performance, and talk about how things really work.
Welcome to KIMEcast. Tony and Russ. We just finished our advanced phase 3 high performance director first class this last week in our first phase, which was outstanding. And our focus of that phase was discussing communication and the importance of communicating clearly to the client, to the patient, so they can clearly understand what the condition is and what direction they're headed in to get this problem solved, so they get back to the activity they want to do. And the concept here is that if you can't communicate clearly what someone's case is or why they're feeling what they're feeling, then you're going to lose the opportunity to help them with exercise or other coachings down the road, because they're just not going to buy into what it is that you're presenting. And if you can't get them to attend to the session or participate in the exercise or treatment process, then you're probably not going to be very effective, right? So it's about, can you take your knowledge that you have on the condition and can you use the right language to communicate to the patient so they understand where it is you're coming from and they can internalize it. So we have two kind of things to discuss here. One is basically 5 larger concepts of conversations that you would have with the patient. And then based on that, we'll go through some specific examples or cases of things that we use in the clinic and things we say in the clinic, so that there's some common analogies that you could pull from, or you could see how we organize it in such a way that it comes together. But the first thing is collecting a knowledge base that you can have those conversations. So Russ, what we got for our overarching kind of 5 big categories here?
Yeah, so in list form, let's just tackle one by one. So the first one we kind of labeled tissue healing, but this I think the story starts from when we first have pain, and we can agree that the first phase is inflammation and it hurts, and we have to articulate that to people because they're in pain and they don't know what to do, and we have to say something about, this is the inflammation phase. This is what you're going to expect because you just injured yourself 2 days ago. And what does that inflammation story look like? What is it? And why is it hurt?
Perfect. And then number 2?
Compensation. So the compensation, we say that, patients will say, is this compensation? Or we as a therapist will say, you see how this area is weak, that means above or below has to compensate for that lack of movement, that lack of stability, lack of strength. When you have a lack of something, you're still going to walk, you're still going to get up out of the chair, you're just still going to try and run, you're still going to try and do life, and your body has no choice. When you have a lack somewhere, something else has to pick up the slack. That is compensation. And why does that hurt? Why does that lead to pain? Why does that lead to further issues down the line? So we have to answer the compensation.
Yeah, this is a common one. I've heard previously, they hurt their ankle and now they have hip pain, and how are those two related? Absolutely.
And we have another one where the common person who moves a lot, they might do a lot of the thing that they like, whether they're a hiker, they're a baseball athlete, they're a jiu-jitsu practitioner, or they maybe just like to do a lot of sitting. There's this, we as humans tend to do a lot what we like, and we kind of have this concept of fill the bucket. And you can also consider this the law of diminishing returns, that if you do a lot of something, you're experiencing the end of that bucket, whatever reward there was by sitting down and watching a movie. The reward's done. Don't sit for the next 20 hours because you filled that bucket. Bad things are about to happen. We can say the same thing for deadlifts, but the fill the bucket.
Yeah, just an idea on the same lines of, like, there's a spectrum in life and a spectrum of movement that you have to have. Each of these buckets of your movement continue to have to be filled, or we use a pyramid scheme, and each bucket in the pyramid has to be filled. And if they're not, then you're going to be kind of off to one side of the spectrum and missing other elements. So if someone would say that they only played a certain sport, all I do is play basketball and I don't do anything else, that has its problems. You probably need to do some strength training, you do some balance work, other things you need to do to kind of balance it out. But you need to do some flexibility work. Other side of the equation, maybe all I do is yoga. I might hear this a lot more often. Is all I do is yoga or Pilates or something like that, and that's what I do. That's how I get stronger. That's what I challenge in my body. Nothing wrong with that. It's a great practice, but you might be missing some other elements
if you look at the big picture, look at your whole spectrum. So it is a big picture discussion.
Yeah.
If that's big picture, the next one we are going to into is more focused, and the focus would be of a mobility issue. Something's not moving well, so is there good joint congruency? Is there good connection? Does the joint articulate well in a non-painful way? And that we look at, freedom of the joint, freedom of the connective tissue, as the muscle, the tendon, the fascia. So looking at that overall movement system, and explaining that. And the last one, if you've been hurt for a while, let's just say longer than a few months, you start falling into the chronic pain category, and that definitely deeply affects how your brain interprets the signal. So how do we explain to people? How do we move the needle in that discussion?
Right. So these 5 categories that we find ourselves usually communicating to the patient would be: 1 is either regarding tissue healing, 2 around compensation strategy, 3 would be fill the bucket or a movement spectrum, 4 would be there's a mobility deficit, range of motion loss, tissue dysfunction that's limiting the ability to move, or 5, they've moved into a chronic pain cycle. So explaining something in each of those categories, we find ourselves coming to with each evaluation, with each patient, we see it's something in those categories. So we want to give you some examples. Now, let's say we just pick a few cases that are really common. We'll start with that, and we'll give you some examples of how we might discuss a certain type of condition or a certain problem within a certain body part. So very, very specific. Share with you the analogies we might use with the patient so that you can get some examples of this and kind of bring it to life. So I'll go first, for example, and I'm going to probably include multiple of these categories into this conversation so you can kind of get an idea of how it might go. But let's say the patient comes in, the case presentation is low back pain, and it's maybe, what's the word when it comes out of the blue and it doesn't have a mechanism?
An idiopathic.
Yeah, that's the big word for me. I'm good with 2 syllables. When it gets beyond that, it starts to extend my skill set significantly. It's communication talk. But the idea of it's idiopathic, don't know where it came from. It's been around for like 3 to 6 months. It's maybe it comes and goes, things of that nature. Why is this happening to me? And if I go through my evaluation, I use I'm going to go through, I'm going to range of motion, I'm going to look at their strength, and then I'm going to come to this conclusion and be like, okay, based on these tests and these assessments and watching you move, and these variations we go through, this is what I see, and this is why I see it. So that conversation will go like this. So if you look at your spine, what we know is that the spine is designed to move. It should move. It's healthy if it moves. The more that it moves, the better. What you have in your case is maybe there's a weakness or a pathology or a disc, or you name the thing. There's something in your spine that might give you pain when you go to these extremes of motion. But the problem isn't that the spine is moving. The problem is that it's moving maybe more than it should. And why would it do that? Why is it moving more than it should? Well, it's likely that either your hips are too stiff or your thoracic spine is too stiff. So if we have a stiff rib cage and you ask your body to look over your right shoulder and your rib cage doesn't rotate to the right, well, now all of your rotation is going to happen at your low back. And when you did that test, so we rotated right, you hurt in your low back. And then we measured your thoracic rotation, noticed that you don't have any rotation to the right. So therefore, there's no option for your body except to rotate in this spot. So this spot's moving much more than another spot, which would be a compensation. And therefore, it's putting trauma and stress in this area. And the solution to that is not necessarily to just make the pain go away, make this feel better, but to actually improve movement at an adjacent joint area in the thoracic spine in this case. So a treatment plan is going to be, let's work on your T-spine and get that movement so you can rotate a little bit better. That'll take stress off of this area while it heals up. And then we'll also do some localized treatments to facilitate healing in this area. But we're not going to stop moving. We just have to be aware that your movement is happening at one spot. We want to split that up over the course of multiple segments. So that would be kind of my go-to, this is what we're going to do, and I'm going to give you these series of exercises to correct this problem, right? Could be the same thing could be said if it was the hip. Maybe the hip was stiff and into rotation or into extension. Same conversation, different set of exercises. But the concept is the lack of movement above or below is causing an increased amount of motion at this site.
I think that exact story, when you get good at that story, you apply it to the neck. You apply it to the glenohumeral joint. You apply it to the knee. And we use the One of the principles we use is the joint by joint approach. Spoke first with Greg Cook and Mike Boyle about 20 years ago in an article that they labeled the joint by joint approach. It's a great biomechanical lesson. I would say it's a very early principle. The first principle is really understanding biomechanics and physics and how the skeleton's made. What follows then is look at these structures, and you see that there's alternating preferences of each joint system to either be to enhance a little more mobility or enhance a little more stability in the skeleton. And so in those areas, the knees, low back, the cervical spine, and the glenohumeral joint, there tends to be, our body is given a lot of mobility in this area, which means we need to feed stability. And if the areas above and below have either stiffness, hypomobility dysfunction, or they have, or they're weak, then those areas that already move a lot, they're going to move a lot more. So the compensation strategy is critical for those areas, and it can explain ACL meniscus issues. It can explain degenerating cervical spine issues. It can explain labral pathologies, rotator cuff tears that are in that chronic state or athletic state. So to get good at the compensation strategy is really important. We have teammates, and we need to label these teammates. And if one teammate's not doing their job, that means the teammate next in line has to make up too much of the task.
That's a great one. Like within that story is that idea. I think there's a lot of people relate to the idea that the 80-20 principle is common in like the workforce. So most people have a job where they work with people, and they've heard of this, that 80% of people or 20% of people do 80% of the work. Right?
The Pareto principle.
Yeah, exactly. And then when you're the one doing all the work, you're the one that's tired. You're the one that's mad. You're the one that's frustrated. You're the one that's going to probably, call somebody else out, right? Which is your body's pain signal. It's mad, it's fatigued, it's tired, it's yelling for help, so you get this pain signal. Meanwhile, the other body parts that are stiff and not moving, they're not doing any work. They're good. They're just chilling, staying in the same spot, no problem over here, don't look at me. And that's what's happening in the body. So people, you explain that principle, and then they're like, I get it. So I got to make those guys over there go do some work, and it'll take pressure off the other ones. So that goes over really well. It's easy for someone to understand.
Well, think of how many diagnoses that we are given that all they do is tell you who's yelling the loudest because they're doing all the work. Low back pain, the disc is blown, labral pathology, tendinitis. I have IT band syndrome. What do I do for IT band syndrome? That's literally just saying the lateral aspect of your knee hurts. Let's just call it majority of these diagnoses that we get are not labeling a dysfunction. They're not labeling why the person is compensating. It's just saying that spot hurts. Yeah, they didn't really tell us much because the person already knew it. Because they said, "Where's the hurt? Right there, one finger." That's how smart our medical system is from an MRI standpoint, right? It just says whichever is barking loudest.
Yeah, that's exactly it. So be cautious with that. But look at the whole thing. So we like using the joint by joint approach, helps explain compensation, and it's a really nice tool in an atraumatic environment as to why someone might have some buildup of pain. And usually you find the source of the problem there. We're not suggesting you make this up, but rather understand the process and then be able to communicate using these analogies so that people can understand.
I mean, I'm so glad you brought up the Pareto principle because nailing that story is probably 80% of our evaluations. This is probably the most common
in most cases. Yeah. Okay, so let's do another example of another type of condition. Maybe we can take. I like this one for example. I can talk about the rotator cuff. I think you have to have a way that you describe how the shoulder works to people, because the shoulder is interpreted as very complex, and they're always trying to understand a rotator cuff tear or a labral tear or a biceps tendonitis is really the big three. Maybe they have something else, some bursitis, whatever that means, and then maybe there's some instability. These are all, to me, they're all wrapped around the same idea. So when I'm working with a shoulder, my conversation is typically similar to each client when I describe like how it works, and the fact that, and then this is how it goes down, right? So we get, before I get into it, there's some theories you have to like understand that I'll speak to at the end as far as scapular control and rotator cuff function and this and that. But usually my conversation goes like this. So if someone's talking about their shoulder, they're asking about the rotator cuff. What does it do? I tore mine. How are you going to help me? Right? Because like we know that they've read on Google already that he doesn't heal very well. So what the hell am I going to do to help this person with a torn rotator cuff? So then I explained to him like this. Okay, so here's your rotator cuff. You have a ball in the socket, and you have a really large ball and a very small socket. And so naturally that ball is very unstable and moves around quite a bit. But the benefit of that is you have tremendous amount of freedom. You can move your shoulder in so many different directions. So we rely on our rotator cuff to come in and grab the ball and then create like a suction showing like it grabs it in all three dimensions. So it stabilizes the ball. And what the rotator cuff does is it grabs it and it pulls the ball into the socket and it holds it stable there. And when it does that, now your big muscles like your deltoid or your pecs or your trap, your biceps, your triceps, they can then move your shoulder around because the ball is now anchored in a stable position and it can now pivot in the socket freely. If the rotator cuff is weak or it's damaged where it's not able to stabilize the ball in the socket, what happens when your deltoid kicks in is that the ball slides. And when it slides, that's painful, might cause things like impingement because it's going to cause more swelling. It's certainly going to feel very weak and your body's going to go into an inhibition mode because it's not going to fire the deltoid in full go because the proximal part is not stable. You're not creating any kind of a fulcrum or any kind of leverage there. So this is why we have to strengthen your rotator cuff. We have to get it engaged. We have to activate it, turn it on. And they might ask, well, how is that possible if I tore it? And they're like, well, you have 4 muscles. And if you're standing in front of me, you probably didn't tear all of them. It's unlikely you tore one completely. You probably have a partial tear of one of the 4 or section of the tendon. And I might even get into describe and say, you know what? Actually, when we go into the cadaver and we look at your body and we look at the tendons, it's very hard to differentiate between each one of these tendons. They very much come together as a symbiotic tendon. So you have a damage to one, but they work as a team. So even if one's damaged, we see people can do very, very well as long as the teammates are all doing their job. They're all working together. So what we're going to do is we're going to go after these areas. We saw in the test that you were weak with this motion and you were weak with that motion. And of course, you hurt when you reach overhead. So we're going to get strong with those motions first. We're going to build up some good strength and then see how it goes. And as it gets stronger, I think you're going to see you can move much more freely.
I think a follow-up to that story is that they oftentimes ask, like, well, but Tony, I have a full thickness tear. And as if a challenge, like, I'm not so sure this is going to work. And then our follow-up story to that is, well, you still have some part of that tendon attached, and it can get really strong. It can get so strong that you could live and die with that tear and still play tennis every day until you're 90. That's the cool part.
Yeah.
And then they'll say, no one's ever said that. And now I have a reason to believe I can do this conservatively or with injection support. Because without that direct feedback that, yeah, you could have a torn tendon and it could be strong. What's the problem solved to? Let's get a good stability system because of this very mobile segment.
I think what's in people's mind is they see this, they think about a tendon as like a rubber band or like a bungee cord, and they feel like it's just been severed.
Yeah. But once it's going, it's just going to pop right out. It's just, boom,
and it's
done.
It's 2 separate things. So how could it possibly still function? So that's another good example. So you can say a bungee cord. Imagine that you just like cut like a tenth of the way through it or halfway through it even, and there's still quite a few fibers that are still engaged, so they're quite strong and can do their job effectively. Yeah, then you could quote research and stuff if you want to go down that path. Depending on who you're talking to, I think it's important to recognize that you got an engineer in front of you who might want to hear the research. Maybe you go down that path, and if you have somebody who doesn't, then you don't have to go that far. But I think that is them, right? Be able to show them the end game as possible. The other conversation that's common here is, do you think I need surgery? And which is a very difficult thing to ask and takes, I think, tremendous amount of experience to already guess that on day one. In 20 years, I still don't answer that question.
Yep.
Because I can't.
Yeah.
I have no reasonable evidence to say yes or no on day one. I could say the odds are maybe in your favor, that's a better path. It'll be hard to avoid it. Or I could say the odds are in your favor that, you can do really well. But what I'll tell them is I'll say, hey, I don't know how well your tissue is going to respond. But what I do know is you've got weakness, although you still have some functions, not perfect. What I know is that if your tendon is attached and if it can get stronger, I know that we can make it stronger. So let's give that our very best effort for a few weeks, and let's see if it starts to respond. If in 2 or 3 weeks you're getting stronger and moving more, hey, let's see how far we can take this thing.
Yeah.
And then one of two things is going to happen. You're either going to get to a point where you're like, hey, I feel great. I'm strong enough. Thank you. I can do my life. I can go back and play tennis, whatever it is. Or you're going to get to a point and say, like, you know what? It got stronger, but I still can't raise my arm as high as I want, and it still hurts all night long. I think now it's time to have surgery. And I'll be like, great. Then at least you tried everything you could in your power to avoid it first. And if that's the outcome you come down to, then we can all sleep at night and be like, hey,
Yep.
that's the best choice for you is have surgery. You tried.
Yep.
It didn't work. Let's go get it fixed.
And
At worst case, you lose like a month.
And you'll have a better outcome because you did exercise prior.
Yeah, right. You prepped yourself better.
I think in this exact same case study of a shoulder issue, let's now change it rather than having torn tissue. Maybe tissue is just beat up and it's inflamed, and we want to look at why is it being beat up and inflamed. And you find someone has a mobility dysfunction. So a common one might be, say, a lack of internal rotation. They can only internally rotate maybe, say, 20 degrees while they're in a supine position. And they lack thoracic rotation. So they can't, they can only rotate 20 degrees thoracic rotation to the involved side. And then you say, like, well, you have these dysfunctions. That's why you hurt. And then the next question is, well, I've been tight like that for 30 years. Why now? I don't buy it. Why does tightness make me hurt? I've been tight like that forever. That's a tough one. What do you say?
So when I talk about the rotator cuff, especially the cuff, because I have seen this to be true, I'll talk to you about like a pair of jeans. I'll describe it like a pair of jeans. So I'll say very rarely, if ever, does someone come with a traumatic rotator cuff tear. Sometimes you get it, but even then they're usually over 40 and they fell off a ladder or something extreme happened. But you don't see rotator cuff tears in 20-year-olds or 25-year-olds. And the reason being is that it's a wear and tear problem. So what you see is that, imagine like a pair of jeans. Like you had your jeans and you bought them without holes in them, all right? And then back in the day, you actually used to wear them long enough, you might develop some thinning in the knees, right? Maybe you were doing work, actually manual labor, and you thinned out the knees of the jeans and started to thin a little bit. And then maybe eventually it kind of opened and there was a small hole that formed. And then that hole got a little bit larger and larger, and eventually it becomes a problem where now it's getting snagged on everything. And now, you're just putting your leg through the pant leg is difficult because that hole is so big that your foot gets caught on it as you put your pant legs on. So that's how the rotator cuff functions. It starts off good when you're young, and then it wears over time. And yours might wear faster than somebody else's based on your genetic tissue, or by your stiffness. If you were stiff in your mid back, you haven't given your shoulder very much room for air, so it's allowed it to perhaps have some more rub or some more wear and tear on the same spot over and over again, and you've created a bit of a wear and tear hole. That now we could go in and they could either stitch it up for you, or we could stop this wear and tear and start minimizing how much more wear and tear you have by working on your stiffness in the meantime.
I use the jeans at least maybe every other week. It's a very common one. I think the whole point of this podcast is to find stories that kind of connect with people, and the jeans is a good one, and the wear and tear, because wear and tear is hard to understand. But everyone has a pair of jeans they've had their favorite pair, and they wear them a lot, and then it's thinning. Now you've kneeled a little too much on that sucker. Similar. I think the other part to that case was going back to the stiffness. And so when something is stiff, that means something has to move differently. It has to be stressed differently. And so, last time I checked, gravity is always pointing toward the middle of the earth, maybe slightly off the center core, but mostly down. Gravity goes down, which means our arm hangs down. And if our arms hang down and we don't have good internal rotation, then our scapulus tends to kind of pull a little bit with it, tends to kind of anteriorly tilt the touch, protract some. And that is a really interesting thing to our rotator cuff. It takes the shelf of the cuff, and rather than make the shelf like this, it kind of puts a little more vertical, and then our rotator cuff tends to be stressed. And so this goes back to the compensation principle, that if we have this function here and we have this function here, we are stressing the system constantly in a really poor design. It's not how our skeleton was designed, and we got to reestablish movement so we don't have compensation. And that goes back down to mobility. And for some of us, we need to stretch. I think the older we get, the more I say stretching is kind of like flossing. Just do it. You don't have to debate Like maybe I don't do it today, maybe I do. Brush your teeth and floss. You need to go ahead and open up your body. Go ahead and stretch. Every day, every day. No doubt. And then on that topic, we can talk about another case that has a more of a compensation conversation would be like scapular winging or scapular dyskinesia, if you will, or six scapulas, what they called it back in the day, because the guy put out a study and called it the six scapula. He had 3 different studies on it. It was really quite good from a medical perspective. But I think we've looked at the scapula wrong for a long period of time. So I think for us, again, before I get into the statement, what if we look at the scapula as far as what we're thinking here at KIME is, what's the thoracic spine do below the scapula? If that's not moving well, then the scapula has no choice but to move poorly. The other thing to consider is that what's the rotator cuff doing? And if the rotator cuff can centralize the ball on the scapula in the socket, then the scapula has the freedom to move to try to centralize the ball in the socket. The scapula can move. It's a floating bone. Yeah.
It's essentially a sesamoid bone.
Yeah.
Outside of the AC joint, which you would debate is actually a strong connection. But it touches the AC joint to the clavicle to the SC joint, and those connections are quite minimal when you consider the amount of load and function this thing has. So I would consider the scapula essentially a sesamoid bone. And the reason it's moving is because it doesn't have very good supporting casts in the T-spine or the rotator cuff would be my first thoughts and approaches. So you got to evaluate that out and see where you are. And that's going to lead you towards this conversation with the patient. It's like, well, why is my scapula winging? Or why does it impinge when I raise my arm over my head? And then the answer is going to come down to probably, is it a stiffness problem in your T-spine or is it a cuff control problem at the glenohumeral joint? And then you're back in the same place you were. And then you get back into like, okay, well, how do I train it? How do I get it back? It's a young person, which typically is where we see that at. Then we move pretty extensively into our closed chain progressions and such because, frankly, they respond better. You learn how to use your scapula originally by crawling. So we want to restore you back to closed chain movements because that's how you learn that's how you develop scapular control and glenohumeral control. And even if you look at all the studies, you had all the MVC activities much higher in closed chain than it is open chain. So if the tissue is essentially healthy but just not functional, then we want to load it properly so we can get it to that right state. So.
And you said a few things there, and I think, for each case, let's go still to the shoulder because there's different stories. So you're talking about rotator cuff and tendons, and this tends to feel a lot like sports injuries. Let's go someone maybe over the age of 50, more of a worker, kind of a grinder person, maybe doesn't stretch a lot, and they have stiffness in their body if they're, picking up stuff for a living. Maybe they have one of those jobs where they just do repetitive tasks, they carry stuff, they hold stuff, and maybe they're a bit bigger of a person. And so this person will oftentimes be stiff. And so now we got this humeral head that's kind of big, a small socket, and we have a distinct mobility deficit about how it rotates. This is where I talk about tires. And if you live long enough to buy new tires, you realize it's a bugger. After 30, 50,000 miles, you got to fork over $2,000, spend where you shop, and you get some new tires, and you start realizing, I want to make sure these things, wear evenly, because I don't want to burn them out real quick. Because, if you burn them out, if they're tilted in opposition, you burn it out real quick, and no one wants to uneven wear, because you just fork over another $2,000 way early in the tire lives. I think it was Warren Buffett that once said, hey, if you picked one car for the rest of your life, what would you do with that car? Well, that's our body. We got the one car. And yes, they can replace your tires. That's called the joint replacement. But that's a horrible thing to endure. And most people would not dare wish that upon themselves if they watch others go through it. It's not a wonderful thing to do. If you've had it done, like my mom and my dad, it's a renewed life in your 70s. But let's push that off as far as we can. Agreed on that. And when you have a mobility dysfunction and you can't rotate your shoulder, that means that humeral head can't get into certain positions on that socket, which means that cartilage is going to degenerate. Because that's the only way cartilage gets their health is by contacting the other articulation, the other side, and that compression of the joint gives it its nutrients. That's what we learned in science. That I would call that a first principle. The only way to get that joint health surrounding the whole cartilage is to compress it. So if we lack that normal mobility, there are certain aspects of that joint that are not expressing the DNA at the cartilage level. So I would fully expect that's the area that's going to go arthritic. The first, because that principle of if you don't use it, you lose it. It won't regenerate without a stimulus. And without compression, the joint's not doing anything. It'll degenerate. And using the tires, however you think of it, you can apply this to the back, to the meniscus, to the ankle, the hip, all the areas that we tend to degenerate. And we get arthritic conditions, understand the rubber on tires.
Yep, I like it. I think all I would say on that note, not really relevant to these stories, but think about this, as Russ mentioned there, if you get a joint replacement, it is like a renewed life, certainly a renewed lifestyle, and then said push that back as far as possible. I totally agree with that, except for the fact that don't push it back so far that you start losing other function. I think that's one thing we see is that if people are, say your knee's bothering you, and then you start limping around and you start sacrificing life activities because of the knee, and you let that go on for multiple years, even if you get a new knee back, yes, your knee will feel better, but you've lost so much strength and other mobility and other collateral damage during that period of time where you were suffering that with the technology that's available now for joint replacement, really, that's not our best practice anymore.
Right.
Now, obviously, there's a lot of decisions you made there, but just let that be said. Don't keep pushing that back, but if you can, by all means, do so. I think the other tire conversation, same idea, is that we use it as like the idea of the asymmetry is where the compensation pattern is, right? If you're having a lower extremity problem, if you're driving your car and you've got a front tire blows out or just is low on air, for example, and that car, what's it going to do? Well, it's going to want to veer to the right if that tire is flat or losing air, right? So it's going to pull stronger. And so you can compensate and you can turn the wheel back to the left and get yourself going straight still. But the torque and the force now, the drive shaft as well as the axle and the tire itself is much greater than it was, and that's going to wear out much faster than it would have if you just had put air in the tire, right? So, or got a new tire, but what it was due at the time. But whatever the need is, there you got to go solve that problem. But that's where you explain the compensation pattern to people, that the body is very good at compensating, and it can compensate for years, it can compensate for decades, and then eventually it's like, damn, now I have this other chronic problem that was due to 10 or 20 years of compensation.
And that's the straw that broke the camel's back.
Yeah,
and it's a common rhetoric that people hear. Like, no, I've been doing that. That's not it. Like, well, your body finally had enough. You've been doing it, and now you're, for the 30-year-old, they don't give a rat's ass about this stuff because they have a young body. They can do all the wrong things. Sure, doesn't matter. Get in your 40s, you start to pay attention. In the 50s, oh, they know.
Yeah, that's when it starts to get real. Okay, let's see if we can find one more example. Talked about rotator cuff, talked about like the spine, core. We talked about the knee a little bit as some examples here, whether it be like, I think you might face the meniscus conversation a bit where it's, I'm coming in, I have a meniscus tear, and I play soccer or something. I want to get back. Again, I've read online or heard from my doc or whatever that it doesn't heal. So like, what am I supposed to do? How does it function and such? So I think the conversation with the patient about this to help them understand is you really have to define what the meniscus is and what it does. And I think there's a rudimentary understanding by most people that it's a shock absorber, which is somewhat accurate, but not completely accurate. So the meniscus was a shock absorber. It would be a pillow or a cushion that went across the entire.
It'd be thick.
Yeah, it'd be thick. And it's just, that's not what it is. It's a C-shaped structure that's narrow in the middle and wide at the edge. So it's more of a guide, almost like your labrum would be in your hip or in your shoulder. So I talk about all of these cartilage tissues in the same fashion. They're a guide of motion. And if you're moving within a range of motion in the middle joint space, like, you're usually fine. It's usually not going to be too big of a problem if you're using your middle available range. But when you start to get to the end ranges, that's when things get worse. So in the knee, it'd be like full flexion or full any string in your knee out, where that meniscus is going to get more torque. Because in both cases, you're going to add this torque on, and you're going to create a bit of shear that's going to pull on those structures. And because of that, that's usually where you get your problem. So what we can do is we can strengthen you up through the middle zone. So we can really strengthen their supportive tissues, strengthen the muscles, the tendons, essentially to support the joint. Let's avoid those end ranges. Let the meniscus have a chance to heal. Will it heal? I know. We'll talk about that in a second. But if it can heal and it does, great. Then we can restore full range of motion, and we can start to get back to full activities, no problem. If it doesn't heal, then we have to see, is it in a bad spot? Sometimes you can have a tear that's in a spot where you may have had that tear for years. You just recently flared it up and got irritated, swollen, or got bruised, whatever you want to call it. It's caused a new inflammation cycle. We got to let that calm down, run its course. Maybe we go back to where we were. Or maybe it got worse than what you had, and it's not going to fix itself. It's not going to be okay. It's going to be in a bad spot. If it's in a bad spot, then we're probably looking to go down the operating room and get this thing cleaned up.
But because it is a guide, it's not contractile tissue. It doesn't necessarily rob you from strength, speed, or power. And so then we have to ask ourselves, if it's the guide is gone, then can you still control motion? And if you can, a lot of times you just be patient with these, and they can. Healing is an interesting word, and if you say healing means restoring back your function, then a lot of people heal from this. Now, if you say heal means reconnect and tether down so that it's stable, it's less so. When it's in the avascular spot, they probably won't heal. But guess what? Your body can chew it up. Your body can do its treatment, kind of like the doctor. I'll say often that if you have the majority of people who have their knee looked at after they've lived a long 9 or 10 decades of living, they don't have a meniscus left. Where'd it go? Where did the disc go, for that matter? So a lot of times your body can slowly degenerate the tissue, eat it up, chew it up, debride it out, and so then you have to ask yourself when you have these type of injuries, can you function? Can you move? Can you do activities? And your body can, I would call like self-correct without surgery, maybe just an injection support. And I think as medicine goes on, the reason why you're seeing so much injection support is because they're learning if we just help the joint stay healthy, the synovium not be as inflamed, the tissue still vibrant and able to move and express itself, the body does self-correct. Maybe not surgically fix, not reattach, but get healthy again and consequently not painful. And so that teaching that story of what inflammation is for to stop us from moving in that area for a short period of time to get to the next phase, it helps us at least get an idea of what's the goal of therapy versus is it torn, do I need surgical support? And I think the best surgeons out there are very aware of this, and they're buddies with the injection support people, and then they're buddies with all the therapists in the area because they realize, let's do surgery on people who need it where it makes sense. But if the body has a shot to self-correct, then give it a shot, because surgery is a huge undertaking that takes its toll on people.
Yeah, that's a great point. We're talking about inflammation. Tissue healing is one of our top categories here, and this is a good example on the meniscus where we're talking about inflammation and controlling the inflammatory cycle is massive. So in explaining this to the patient, I'll oftentimes use the science. I'll be like, look, inflammation is a 3 to 5 day thing. You need it because it's going to bring all of the right cells and to change the chemistry of the joint to support the healing process and get this thing laid down. So imagine if you cut your skin and you were starting to bleed, you'd form these platelets, you'd form a scab, and that's the inflammatory process is designed to do, is initiate this healing process. And then you build the proliferation, so you'd build more cells. Those cells are going to start to come in and build a bridge or fill in the area if possible. And then you're going to have to then develop some tension through those cells, so they're going to form into the tissue you want them to form so they can tolerate the forces you're going to put on them. So that's the remodeling aspect. So as we teach them that, then I'll correlate that with so for the first week or two, we're going to be more inflammatory management strategies, and then we're going to move into more of some early loading strategies and start to move the body and move the tissue while it's proliferating, and then load it in such a way so it can remodel and do what it is you want it to do, and explain that cycle to them. And then of course you have to explain, well, why have I been in inflammation for 6 months? And then that conversation is a much bigger one. I said, well, do you keep re-aggravating it? Do you never let it heal and just keep re-aggravating? Do you have chronic inflammation in your body from nutritional habits or sleep habits or other factors, stress, other factors that you're not addressing? Is it just continuous abuse? So it's usually one of those two big things.
That's a big one when you see inflammation return. Something is amiss when inflammation returns. Whether it's sleep, stress, aggravation, you're doing the wrong activity. And I'm doing this with a young super athlete right now where the pain returned and there's a misstep there, and trying to figure out where was the misstep? Why was the tissue on thread again? What created that thread? and then to reestablish inflammation control. And it's because it's defeating. When people need answers, they need good answers in this space because they feel like they just got re-injured and the timeline started once again. It's like they went back 2 months, and they need to be talked off the ledge, so to speak, and say it's just re-inflamed. All of that prior work still did stuff, and we'll be able to lean into that once the inflammation cycle is calms down a bit.
Yeah, totally. This comes up a decent amount where there's this type of situation where it returns, and then you have to work with them on understanding how to control the cycle, what's there for, and why they're in pain. And for inflammation, I refer to this a lot with people like back pain, shoulder pain, knee pain, whatever it might be. Is all right. It's a 3 to 5 day cycle. It's going to cause some swelling, so there's going to be a lot of pressure. So what you feel what the pain is coming from is the pressure of the extra fluid and the extra cells in the area, and the chemistry is different. So that's what the pain is. So a lot of times, like for back pain, folks, they'll have pain at night, or any extremity, they'll have pain at night, and they're like, "Why does it hurt so much at night and not during the day? I can get through my day and I'm okay, but when I lay down and go to sleep at night, it's throbbing." So it's like, well, that's because in my opinion, that's because of inflammation, because they've been moving throughout the day, so their muscles are pumping the fluid's moving, it's not really building up. But when they stop moving in the evening or they go to lie down for bed, that now that they've stopped moving, the fluid is allowed to pool a little bit, so it's increased pressure, which is going to give you a pain signal. And you also are going to be inherently much more aware of your body when you're not moving, so maybe that all of your senses are focused around that as well. But usually to treat that, then we talk about, what can they do to reduce inflammation prior to bed? Can they use compression? Can they use IUs? Can they use an anti-inflammatory of some kind to minimize that process? And then once they understand why it's happening, they can usually neutralize it very, very quickly. And you can't start at 10 p.m. You've got to start at okay, hey, my day's wrapping up at 5, 6 in the afternoon. I need to start now at 6 or 7 p.m.
Yeah.
Hit it again at 9 or 10 p.m. And then when you go to bed, then you've kind of done something to kind of outmatch the inflammation that is coming.
This is why, whether you have a joint pathology or a tendon pathology or even, ligamentous disc neuralgia, isometrics can be one of the easiest paths to bow nearly all of it. If it's tendon, you get a low-level isometric. It helps express, good collagen synthesis. If it's a joint pathology and you're more of you try to kind of battle a little bit more of the fluid accumulation. Get the muscles pumping in simple ways. Do some simple isometrics or some medium range activity that's not too threatening. And this is where just doing, frankly, just easy low level exercise can benefit all of this. And you do that, you're able to get away with that story because they've understood what inflammation is, and the enemy is not necessarily inflammation; it's the return of inflammation. So we have to some degree, just kind of get our body to that next level, and that means don't get sedentary, because that's what we know that's bad. If you just sit and let things pool and let things accumulate, there tends to be an increased pressure. So whether it's elevation, whether it's a little bit of light compression, whether it's a really easy isometric or a very medium range activity, we can do something that kind of teach the cells to continue to move and flush, and we get past that phase every time. Unless they need surgery, then they're done.
That's fair. So we talked about tissue healing, we talked about compensation patterns. Let's talk a little about this one on fill the bucket, or this law of diminishing returns, and kind of look at the spectrum a little bit. So I had a good example just a couple weeks ago, a young lady who's very bright, and we've treated in the past for her back pain, and she's done very, very well, and very, very active, lifts, exercises, very active, like kind of mid-20s, so not an old body, but she demands a lot from it. She's very hypermobile by nature. And so she self-incriminated herself, and she's like, well, I've been doing a lot of deadlift. And she's like, I'm like, okay, well, what else are you doing? And she goes, well, mostly just the deadlift. And I was like, okay, so you know that's not okay, But for a month straight, she really wanted, she got caught up in, some challenge at the gym or with friends that, hey, get your deadlift better. So that became her primary focus, and there's deadlift. So she did a lot of, not necessarily anything heavy, and never had one day where she did it and she went to the ground or took a knee because of pain, or did the back fail, anything like that. But 1 week, it kind of was like, boom, she woke up one morning and she's like, there it is. Like my back pain's, it's different than it was before, but I definitely know that I'm not right. I feel like I'm shifted, et cetera, et cetera. So we went through the whole, she's like, I feel a lot, but this is a week prior. So then we did the eval was a week after. She's like, I'm actually not in pain today, So she's like, I feel better than I felt in a long time. And I feel like I'm good. She was, I had the appointment, so I still figured I'd come. I'm like, good, glad you did. So we ended up figuring out, going through the evaluations, you really had no limiting factors, range of motion wise, which is always true. She's super hypermobile. Strength wise, she checked all the boxes. There wasn't any obvious super deficit in strength in any plane or any direction. And we challenged her extensively, like doing Roman chairs, doing different plank holds, doing flexion with rotation and loaded bed balls, like all the different planes and movements, different speeds. Nothing exacerbated the symptoms. So it was great. So I was like, hey, I think that your problem is that you went one dimension with your training. And when you go one dimension with your training, your body's adapting and you're causing it to adapt in a bad way. Like you asked for a bad adaptation pattern. Now you have tension in certain muscles that are far too tight, and all of the teammates, the other ones, they're not responding because you haven't been dynamic enough in your training load. So you've been too consistent doing the same old thing. So we went back to our basic principles, which almost always answer the questions, which is why we have them as basic principles, is to, you went to this lot like 5 or 6 sets of 3 to 4 rep type of a situation, which is a great way to build strength. I have no problem with that. But if you do it without considering other variables, you're in trouble. So we went back to increasing time under tension as a treatment strategy and be more dynamic with your training load. Let's do things in different planes of motion as opposed to consistently do one thing.
Exactly. And when you are more, dynamic, say you had a squat, a split squat, do a swing, do a get up, do some variational load, you realize that different exercises expose different things. And one thing that I realized about, there's no one perfect exercise. Why would we ever pretend? Most of the exercises where the barbell or the dumbbells in front of us overloads the back. And what I mean by overloads the back, I can say the same thing. I can say it underloads the front. It might be another way of looking at it. Because I think a person might say, what if I just want to get really strong with my deadlift? Fine, as long as the front side can match that power. And if you're deadlifting, say, 2.5 times your body weight, and your stomach does not have the strength to support that type of backside power, you'll hurt. You'll hurt your body. You're filling up one bucket without filling up the others that kind of keep your body into some degree of balance. So I think there's a lot to be said for building a body in balance. Now, even if you do all of the core stability training and all of the thigh building in conjunction with your deads, we'd still say there's a law of diminishing returns. That once you start getting into really great strength with a particular pattern, no matter what, you might get your risk reward starts to change. And it kind of really depends, like, do you want to compete in powerlifting because you're turning yourself into a powerlifter? So we try to kind of set these thresholds to people. If I've recognized that some people, they just need to be told, you've met the goal. You're strong enough in that lift. And so for a lot of male and female athletes, if you're deadlifting more than 2 times body weight, I ask, do you think you're strong enough for your sport? Do you think we should start building more power and speed and ballistic and conditioning? There's other things to do besides this. Now, if you're in fitness, as I'm assuming your patient was, then they're doing it for some other reason. They've been challenged by their friend. They've been challenged by their coach. They're doing it for beauty. And it's like, if you're doing it for beauty, you can do single leg deads and hip thrusters and other things that aren't as threatening. I think there's plenty of great researchers and influencers that are promoting the hip thruster. You're less likely to injure your back doing hip thrusts, and they're hard. They're more of that self-limiting exercise where if your hips don't go up with the hip thruster, the weight's not going to go up. Whereas with the deadlift, if your butt doesn't do the work, your back will do the rest. That's for darn sure. You'll lift the weight. It'll just solve it in a way that tends to have an issue. So going back to fill the bucket or the law of diminishing returns, have you gotten the bulk of the reward with that particular pattern? And if you have, are you just getting greedy, or do you have a more powerful reason why to excel with that pattern? Why? Why do you want that? Because no matter what, the risk starts to becoming higher while the reward gets less. That is exactly the law of diminishing returns. The risk-reward ratio flips.
Yeah, I love it. But so two other big categories that we speak about often would be like range of motion. So this kind of can go down a lot of different paths, and I want to give you guys a few things that we utilize fairly often to solve this. And then the second one we don't talk about much is be chronic pain and the signal that's sent into the brain. So on the range of motion or the mobility front, I think again it comes down to what tissue is the problem. Is it a contractile tissue or non-contractile tissue? And if it's a contractile tissue, then we should be able to make changes very rapidly. And it's about the conversation with the patient is like, hey, we can make this change quickly today. I can probably do some soft tissue work. We can increase mobility right away. Then the question is, can you keep it? So I'm going to give you some stuff to make sure you use it or retrain your body to use it in this new range. That's it. And then it's really up to them to kind of keep it, and you kind of keep picking away at it. The other conversation is like, okay, you've acquired a real stiffness. Like there's actually a loss of elasticity of the tissue. Perhaps it's contractile, or perhaps it's non-contractile, like a capsule or something like that, which I think is more rare than we thought 20 years ago. Everything was capsulized 20 years ago, and that adhesive capsulized and this, that, and the other. I think that's more rare than put out there, but nonetheless, it does exist. So as it does, we do know that the recommendations here are long. You have to dedicate a good amount of time to change it. Again, you try to cause adaptation to the body. So there's a big conversation around, for some reason, your body has become stiff in this capsule. Maybe it was due to trauma. Maybe we can't know the reason. Like in frozen shoulder, we have high correlations with diabetes and thyroid issues that cause this deficit. And we don't really know other than why. There's some sort of chemical trigger that happens. But we do know that to improve it, there's obviously time. But there's also prolonged stretch is impactful. We know that getting certain medications on board help, whether that be a cortisone shot can be helpful or PRP can sometimes be helpful to change the chemistry. We've seen evidence of both of those things. And then there's also closed chain work in the shoulder, for example, that can be very effective. We've seen as well, being like prone on elbows and like rocking back and forth. And again, you close the chain of the shoulder and shoulder function can be restored in a more rapid fashion. None of those are quick. So the conversation with the patients, I'm going to give you one thing or two things to do. And I want you to do this often, frequent, and really try to make a lasting change here. Because if you're just touching it once in a while and the rest of your 23 and a half hours a day, your arm is down by its side, and only for 20 minutes a day, you're trying to get it over your head, it's not going to go. So
yeah, I think as you spoke, when it comes to mobility, we have some things, maybe like an active straight leg raise or overhead flexion. It's like we kind of need to get to a certain amount. For most moving well people, you need at least north of 70, 75 degrees of active straight leg raise. And if you don't have it, you got to give them goals to get there. And that's tough if it's fascial. If it's a fascial line and they're growing, good luck. If they're done growing, we got to fight here. So let's give them some problems to solve in the right way. But there's other there's other mobility things such as, say, lumbar flexion, lumbar extension, or maybe total arc of the shoulder or total arc of the hip. We can look at the ankle, where those joint systems that if we have a range of motion, and oftentimes I'll put on a whiteboard and I'll show like a pie chart and say, hey, this is ideal. You should be opening this way into flexion, this much into extension, or this much into rotation internal, this much into rotation external. So I'll give a pie chart. And I'll say, your body likes living in the middle. That's kind of how muscles and tendons work. It likes the middle, it can control the middle. It's stronger in the middle. The end ranges are harder to control. As we know, that's why functional range conditioning is a thing. That's why dynamic stability in end ranges is hard. You get fully short, you cramp, and it's hard to own that. You get fully long, you feel weak, it's hard to own that. So our body likes living in the middle. Well, here's a normal pie chart, or maybe a pie chart prior to your injury, or a prior chart, maybe or a pie chart from 10 years ago. We need to restore this more normalcy, because if you have a deficit, your whole middle is shifted. And when that pie chart shifts right or shifts left, we tend to cause impingement syndromes. So tissue pinches in the hip, the shoulder, back, and the ankle. And these impingements exist because we took our normal joint system, we just shifted. You're like, oh, we're just going to go 20 degrees to the right. And let's see what happens. We're going to have a new skeleton. I wonder if it works. It doesn't. And so we tend to have all the pinching, the FAI. And so restoring this normal range of motion is helping the joint be congruent And that's where I take my little Sharpie on a whiteboard and I draw a shape of a joint. Say congruent means as we move, things kind of stay in the middle and they connect nicely. And if there's a force vector that pushes it one way, like a tightness that shifts the whole pie chart one way or the other, it pinches. The meniscus can pinch, the labrum can pinch, the disc can pinch, the nerve can pinch, all sorts of pinching. And I think that mobility part is critical.
I love that. I use that a lot. The spectrum where like you have a window and how open is the window. It's some conversation around you've lost some space, only using a small percentage of what you've got. How about chronic pain? Is there something you use regularly with your chronic pain population, like an analogy or a description of how this can be 4 hours, but we're not going to make it that long?
I know. I came up with this dumb one, and it's dumb. I don't really like it, so if we can create a different one, it'd be great. But we can call it, like, from a nerd talk, we can say it's a faulty interpretation of a signal in the brain, and the brain says, "Oh, I'm on so much threat, that must be pain." We kind of say that, but I came up with this dumb one. So I take my finger, and I flick them. So I take my finger and I flick their leg or their arm.
Somewhere it's not painful.
Somewhere it's not painful. Like is if they have a hurt arm or if they have a hurt back and their back is constant or whatever. I just flick an unhurt body part. And I flick it once and I say, "Did that hurt?" And they say, "Well, no." I imagine if I did that 10 million times. So I know it's impossible, but imagine if I did that. The wound, it'd be horrific pain. That's like some sort of, torture, right? And it'd be the worst torture ever, right? And then imagine on the 10 millionth flick, it's all bloody, oozing, it's horrible, and you're writhing in pain, you're in hell. And then I stop. And then the wound gets treated. And say 6 months later, it's all fine. And then someone goes in, flicks it. Would it hurt? You bet your ass it would hurt. It would hurt really bad because we just taught your brain that signal equals extreme pain. So chronic pain, when we think about like an interpretation problem, it's interpreting what shouldn't be a painful stimulus as, "Oh my gosh, that's super threatening. I'm about to die. Don't do that to me ever again." So that's my stupid story.
No, I think that's good. I use that a lot, and not exactly that context, but it's a good one. Just to be clear, Russ doesn't actually do that to people. He just tells them that story, just to rub some ancient. But I use that a lot too, to say like your body's misinterpreted the signal. We have to retrain your body to know that movement's safe, that movement's good, that it's needed, it's necessary. So we have to make it. A lot of times I'll use the word important. We have to show the brain that this movement's important and functional, like laying on your back and pulling your knee to your chest isn't very important to your body. But if you go into child's pose and you rock back knees to chest, that starts to become more important because it's closed chain. And certainly if you were to stand and squat ass to grass, that's more important. And it's very much like child's pose. So you can kind of start with something easy like supine knee to chest, then move to quadruped knee to chest, and then move to like a standing knee to chest, like a squat. And then you got to teach their body over time that movement is okay. And so I explain that to the progression to people in a bit to help them like understand. So to be really superficial, those are kind of like what it comes down to. You can dive much deeper into chronic pain. I encourage you to do so. I think the science on this is expanding just so dramatically. Whether it's David Butler's work is fantastic on the sensitive nervous system. Adrian Lau's stuff on why do you hurt are both really great texts and very easy to read things, and to try and start to speak about this and get your knowledge base up a little more for something that's kind of still something you're uncomfortable with. But I think the perfect teaching moment for someone in chronic pain is actually to teach them inflammation and to teach it how it's different than what they're experiencing. So if they go through some exercise, 5 exercises or 5 movements, and they come back the next session and say, "Oh, I hurt for 1 day because of what you did," I say, "Oh, it's great news. You're not inflamed." And then they "I don't understand, it hurt." That's actually okay. That's plenty okay. As long as you didn't hurt for 4 days. I got a simple rule. If you do a new exercise, 4 days, we overdid it. 3 days, we kind of overdid it, but we're close. 1-2 days is a sweet spot. That means your body will adapt. It's actually not being fully inflamed. There's no way the body inflames aggressively for 1 day and then it flips off the next day. That's not how cells work. They don't go that fast. The phagocytes, the leukocytes,
the mast cells, the prostaglandins, they don't move that fast. Think of this. The last time I tore my ligament doing jiu-jitsu, I looked at the ligament. My partner said, Russ, did your pants just rip? I said, nope, that was my knee. And he said, does it hurt? I said, not at all. Let's finish out this session because in about 12 hours, I'm not going to be able to move this thing. So we had a great session after. I rode on my motorcycle afterwards. So I'm like, so this is perfectly fine. I went to sleep. I looked at my knee. I'm like, in about 6 hours, you're going to be talking to me something fierce. And sure enough, I woke up. It was horrible. Couldn't move it. Ripped the MCL. It was stiff. It was inflamed. It took about, 8 to 12 hours. So I had inflammation to ramp up. And then better believe it hurt for about 4 or 5 days. And then it was done hurting, unless I did something stupid. The point is inflammation is actually entirely predictable when you have injury. So when people have pain immediately after and it lasts for 12 hours, that's not inflammation. Let's just make that clear. And so whether I want to call it chronic pain, I don't get too deep into semantics. I just tell the person, hey, great job. That's okay. We're going to get past this. Because if you can make it cycle, then we know we can change it. We know we can change it. We can adapt. And I use the 4-day, 3-day, 2-day. I just use it on my dad who just got a knee replacement. I said the same thing to him. Like, hey, my rule is simple. If it's 4 days, I did it. I'm sorry. 3 days, I'm not that far off. 1 and 2 days, that's okay. That's what therapy is. You'll adapt. What does that mean? The 10th time you're doing it, it won't hurt at all. That's the adaptation we need. And you kind of have to walk through fire when someone's been through pain. When they've been through a lot of pain, none of this is going to be free, meaning pain-free. There's going to be some discomfort. And if it's kind of in that 4 to 12 hour window, that's okay. I think you can have some grace with someone. You don't need to say that they're a wuss and you gotta step up. I don't think you need to be mean, but you need to completely educate what inflammation is and what it is not. Because people, when say flare up, that's a quick expression to say I'm inflamed. And I say, well, actually you're not. I'll teach you what those mast cells and prostaglandin cells, they actually take a while to come in. And when they're there, they settle, they chew up all the stuff, and then they leave. But that's a several-day process. But whether or not you get that detail is up to you with your people. I usually don't. I do. PTs, we got to get that. Like science. Yeah. All right, so that gives you an idea of how we think about it and how we approach our patients and conversations. So I'd love to hear what you guys have to say. If you have some stories that you use, ways you explain certain conditions, I'd love to hear it. I mean, I think it makes us all better to kind of share these analogies. I know it's, especially as you're early on in your career or even as science is developing, you might learn a new strategy or a new way to explain a healing condition or one of these types of things. So I'd love to hear what you guys do out there to help each other out. So feel free to post that and respond here. That'd be great. So thanks so much for listening, and we'll see you guys on the next one.